terms like restricted reprocessing and unrestricted reprocessing. So let's talk about what that is. So you can almost think about it as a continuum. And so with the standard protocol, we have what we called unrestricted reprocessing. So if we think about a memory, this is a memory, and these are the different channels of association. We're in phase 4 desensitization. We have that analogy that the train is going down the track, right? And so we do a set of bilaterals, pause, we ask the client, what did you notice? The client tells us, and we say, okay, notice that. And we do notice the bilaterals, what did you notice? The client says something, okay, notice that. That train is going wherever it needs to go. There's that memory, and all the different channels of association are coming up. And so that's unrestricted reprocessing. Now on the other side of that continuum, we have EMD. And that is what actually Francine Shapiro originally created back in the late 80s. She didn't create EMDr initially. She created EMD because she thought she was just desensitizing a memory. EMD looks like this, where we have that memory, but we're not letting any channels of association open up. So we do a set of bilaterals, pause, what did you notice? The client tells you what they noticed, and then you bring them back to target. And so you're either going to say, go back to that memory, notice what's there, go into a set. You might ask them what they noticed when you go back to that memory, what's coming up. You might even take them back to the specific components of phase 3 assessment, which is actually how Francine initially created it, where you go back to the picture, the negative cognition, and you take the set every single set. So there's a few variations of that, but basically you're going back to target every single set. And so the client says, oh yeah, just the look on his face. Okay, notice that, and we do another set. The client, then we pause, what did you notice? The client says, you know, whatever they notice, it could be about a different memory. And you don't say, notice that, you bring them back to target. Okay, so go back to that memory we started with, and then you do another set. You're keeping it super tight on this one thing. There's lots of different reasons why we might want to do that. We might do it if something is recent, less than 90 days old. We might do it because we're trying to focus more on symptom reduction, and we want to desensitize just one memory. There's a bunch of different ways that we use it. And so on one side, we have unrestricted reprocessing. On the other side, we have completely restricted reprocessing. And then if those two married and had a baby, we're going to have EMDr. And so with EMDr, as long as what the client is saying is related to this one target, you're going to just say, notice that, notice that. The moment another channel starts to open up, you're going to bring them back to target. So now when you go back to that memory, you know, what are you noticing? And so this is the different levels of reprocessing. So we have restricted over here, which keeps it super, super tight, right? We're not letting anything open up. And then we come here, we have EMDr, where as long as what they're reporting is related to what we're working on, we let that train go. And then over here, we have our standard protocol, right? Where you let anything open up. This is also a great conceptualization for our really complex clients, where we're worried if they're going to over-access or hop out of their window of tolerance or get hyper-aroused. You might start first over here with super restricted reprocessing. And then as you continue to work with your client, you might then shift it to little r and then come over here and do unrestricted reprocessing. There's lots of clinical choice points in here. But if you've been hearing those terms, you know, restricted versus unrestricted reprocessing, EMD, EMDr, that's just a quick breakdown of the differences between all those.